With that, Dr. Ariyan, if you would please come up. Thank you.
Thank you, Mario, and I'll try and stay on schedule here. Now, clearly, in many situations, when it comes to cancer management, a lot of surgeons like to talk about the fact that the greatest percentage of cures in cancers, regardless of what type of cancer it is, and most of them, the greatest cures are done by surgical treatment of the cancer. Well, I'm here to tell you as a surgeon that that's not necessarily true. Clearly, this team that you're meeting today, and some of them you've already met before, this entire team that makes up of 35 doctors on the melanoma unit make up all the fields, not only surgery, but medical oncology, radiation, radiology. These are the physicians and team members you don't get to meet. The dermatopathologists, the pathologists that look at what we're looking at to make decisions about what to do, and then the final result when we took it out, whether it was complete, whether we need to do something more. The therapists, the psychotherapists, the geneticists, these are all part of the most important things of the team, and it's the team that's important, not any one area. So whatever we do, whenever we see a disease and we want to take care of it, everything we do are like rings of a target. The least we do, the least likely we are to achieve our goal, but at the least expense. And the more we do, the more likely we are to achieve our goal, but always at an expense. And the expense could be time, it could be effort, it could be symptoms, it could be scar, it could be disability. For example, if you have a cancer of your fingertip, and we amputate the arm, we can guarantee that you will never get a recurrence in the arm. But obviously, that ring, which is the greatest ring that we do, is not an appropriate one. So you go back one and you say, okay, what if you amputated the elbow? Well, okay, we can give you a 98% guarantee you're not going to get a recurrence, but it's still a significant disability. You go to the wrist and you say, okay, we can make it 90%, but still you can't use the hand. You can go to the finger and we say, okay, we can give you maybe an 80% or 75% if we just do the tip of your finger, and then the disability is nothing. So that's basically the management and decision-making we have to do to determine what is the best and optimum. And you may have 3 different people who have the same disease, and we may treat them differently based on the needs of that particular patient. So this is what we call custom management of treatment rather than cookbook. And this is an evolution that's occurred over the past several decades. So let me talk about recurrences now. I have to tell you some things that some of you may not want to hear, but some of you may actually gain some insight about some of our thinking based on it. This is basically a map or an outline of outcomes based on follow-up of patients with melanoma. Not all patients with melanoma do get recurrences. When they do get recurrences, those are actually plotted out on a curve, as you can see. You can see that the earliest recurrences that we see are usually lymph gland recurrences, and then local or regional, which means between the site of the primary and the draining lymph glands. And then the lowest or least and later presentation are those patients who get distant organ involvement. But you can see it's a curve, and if you look at this, you can see that essentially 2/3 to 3/4 of those patients who will get recurrences, not 2/3 or 3/4 of patients will, but of those who do, 2/3 to 3/4 show up within the first 2 years. 90% within about 4 years, 95% within 5 years, 98% within 10, 99% within 20. So you can see you never get to a 0 point. We sometimes do see patients 20, 30 years later who do get a recurrence. They're unusual because most of them show up within 5 years, which is the reason why we tell you, the patients in the audience, that when you have a cancer, we're going to watch you at periodic intervals for up to 5 years, and then, as I say to the patients that come and see me, you're going to kiss us goodbye. But you never kiss your dermatologist goodbye because you always have to make sure that you do pick up anything else that shows up later on. So based on this, these are the tests that we do to follow up the patients. It's mostly blood tests to check the liver, chest x-rays to check the lung, and then if we find anything abnormal, it may have nothing to do with the cancer, but we can't assume that. If we find anything abnormal, then we go to the other tests to see by CAT scan whether we see anything or not. If we don't see anything, it's less likely that it has to do with the cancer. If we see anything, then we may follow up with some of the other tests to try and focus what's going on. Now, one of the things that's been very helpful is the PET CT scan, because not only does it show us some things, it lets us know whether there's function or activity going on. Every cell in the body needs glucose. It's the fuel of the cell. So that everything we eat, the body converts into glucose, the cells need the glucose. In different parts of the body, the cells are acting much faster. Some engines are running faster, so they use more glucose, so the heart picks it up more. And other parts, like the intestines, may pick up more, which lights it up. On the other hand, if we see a lesion on a CAT scan and it has no activity, it may be a cyst. On the other hand, we may see activity on a PET scan that we don't see on a CAT scan, which suggests maybe it's an inflammation. In other words, if you have an infection somewhere in your arm and a lymph gland is responding to the infection, that may pick up activity on the PET scan, but not show up anything on the CAT scan. So these are the things that we're looking at when we're seeing you in follow-up and we say we're going to get a CAT scan or a PET scan. These are the things that we're using for guidelines to let us know what's going on. One of the other things we may do if we see or feel a bump that's deep in the tissue, we want to know what it is. A simple test we do is what we call a fine needle aspiration biopsy. It's really a painless, I hope I don't have anyone in the audience that say you did one on me and it hurt me, but it's usually a painless thing. We can do it in the office. It only takes a couple of minutes. It's a very fine needle. We stick the needle in, put a little vacuum on the syringe. That then sucks up a drop of fluid from that mass. And that little drop of fluid can then be smeared on a slide. It can be flushed in some saline. And then we can actually have the pathologist look at it. And on the slide, we may see the cancer cells, or we spin down the fluid that's there and get little clumps. And then they can just make cuts through paraffin, take a look at it. And then we can determine whether there is or is not cancer there. But you have to bear in mind, and I tell that to the patients at the time we do the test, that the only thing is meaningful in a fine needle aspiration biopsy. It's very simple, it's painless. Excuse me, I've got a frog in my throat. The only thing that's meaningful is if we see something. If we don't see anything, it can mean that there's nothing there, or it could mean that we missed it, that the needle may have gone too far or didn't go deep enough, or it went into the lymph gland, but that's not the part of the lymph gland that had the cancer cells there. So if we don't see anything, we do still have to take it out. However, if we do know that it's there, then it helps us make the decision a little faster to discuss with the patients. So that's a test that's very helpful for us. And if we do find that there is cancer in a lymph gland, we can go ahead and do the excision. Now, last night I had to revise my slides. Some of you saw that we changed something in the morning because I had a bunch of operative photographs and I decided I've got to get rid of it because I'm talking right after the break. So you'll have very few to look at. But simply we can make an incision in the armpit, get in there and take out the lymph glands, or in the groin. We can make 2 incisions to get down in there and take out all the lymph glands in the area. And for the neck, many of you may have seen patients in the past or may have relatives that had significant deformities in the neck from what we called radical neck dissection. We evolved about 20 years ago into a different technique where we can get in there and do exactly the same operation, but not necessarily take out things that we don't need to. For example, the muscles in the neck can be left behind. The major veins can be left behind. You can see this woman who needs an excision and lymph gland removal has a very lovely neck. And the beauty of the neck is part of that muscle that's there. We can go ahead and do that operation, and post-operatively, the woman still has the function of that muscle, still has a lovely neck, and has had a complete radical lymphadenectomy as in the previous days. So we have evolved in the surgical field to do these same major operations without causing the deformities. And if you go back to the targets I talked about, we can actually go to the bigger rings now without giving the disability and discomfort to the patients. However, we have patients who now present with even less likely, but still present with distant organ involvement. And the question is, what's the decision-making in those, and when we look at the targets again. One of the things that we have to understand that all of us as physicians are actually here because we're all trying to provide cure to our patients, but we can't always provide the cure. And if we can't provide the cure, then we have to care. And the care means to give the patient as perfectly a normal life as we can give them, even though we know, and the patient knows we can't cure them, we can give them a comfortable, full, active survival during that period of time. But it's very important for the patients to understand, we get into a dialogue, for the patients to understand that we must be addressing a specific symptom. If there's no symptoms and there's no side effects from it, the question is, which is better, the treatment or the disease? We don't want to do things that are going to make things worse just because something is there. So as long as we have clear ideas of the specific symptoms, we have a clear understanding of the goals of what we're trying to achieve, and that we can assure that the risk of mortality from the procedure is close to zero, and that the morbidity or discomfort or the complications, whether it's scarring or wound infection, is low, and that we're not going to keep the patient in the hospital for any significant amount of time. In other words, it could be day surgery, or at most 1 day in the hospital. If we can achieve this understanding, and then we think we can relieve the symptoms, then it makes sense to proceed with doing an operation in these patients. Now, this is some data from about 22 years ago that showed that the patients who had involvement of recurrences in soft tissues obviously had a much better result than when specific organs were involved. And from the same institution, when they looked at the data only a few years ago, nothing had really changed significantly for those numbers. However, there are other studies that are coming out that are now showing, again, when you have skin, fat, or lymph gland involvement, we can have the most significant outcomes from the management surgically. But then when you have lung and liver, we're actually getting better responses, longer durable responses in the management of these lesions. For example, this study, which is a combination of different institutions, showed that when it comes to the liver, we're now getting as much as 28 months in patients who have surgical management of this. Now, you're going to hear later on from Dr. Harriet Kluger, I'm sorry, I'm terrible with names, from Harriet, about biological modifiers. There have been significant changes over the last 5 or 10 years that we didn't have before that supplants the use of surgical management. But I'm giving you the data for surgery now because that's what I'm asked to talk about. But one of the things that we found when looking at the liver, and one study that's from the John Wayne Cancer Center in Los Angeles showed that very few patients do have liver involvement. Well, when they do have liver involvement, even a smaller percentage are actually being explored. And usually these are patients who have single lesions. Because if you have multiple lesions, you can't get in there and take out the whole liver. So if there's a single lesion or 2 lesions, and we can go in and take them out, unfortunately, once the surgeons get in there, they find that there are more lesions than they were able to detect, and it doesn't make any sense. In other words, the treatment in a situation like that would be actually worse than the disease, and we have other ways to manage them. But if it's still a single lesion and it is resectable, then a significant percentage of the patients are getting good benefit from the operation. And then when you look at intestinal involvement, again, even smaller number of patients have spread to intestines. that it actually depends. The outcome depends on whether or not the surgeon went in and found that there is so much that he could only do palliation, in other words, get rid of the worst but couldn't take everything out, as opposed to curative surgery, where it was limited to a small area of intestines. They were able to take the whole thing out. The outcome really varied, so that when you have curative, 41% of the patients actually had durable control of their disease. So let me go on to soft tissue and skin recurrences. Well, these are patients who this patient had had a melanoma of the foot. They had resection of all that. You can see the patient has had skin grafts. We actually don't do those things now. But nevertheless, here's a patient who has had multiple recurrences. These are what we call in-transit metastases. It's between the primary and the regional lymph glands. And in-transit recurrences, to me, are like dandelions. If you see a single dandelion in your lawn, that's easy. You go ahead and you take it out. And if you see another one, that's easy. You can go ahead and take it out. But you begin to get a picture that you're going to get a few more dandelions. And then what's going to happen is you're going to have a whole field of dandelions in your lawn. Now, it's important to think of this because the first dandelion didn't cause the second one to show up in the lawn. And the second didn't cause the third, and they didn't cause the others. It was actually from the previous season when the dandelion turned into the fluffs and the seeds got in the air, spread all over, and they got into everybody's lawn, yours and your neighbor's. And it's interesting because one lawn may show the dandelions and the other lawn may not. And not all of the seeds will germinate. And those that do, they won't germinate at the same time. They germinate at different times. So when we see somebody with a single lesion in a leg, we go ahead and we remove it because in 10% of the patients, it's the only thing that'll show up and they'll never get another one. But we also let the patients know, you know, it may be a sign of additional ones that are lying dormant and may show up. Now, if they don't show up, it doesn't mean they don't have any other cells up and down the arm or the leg. But it may lie dormant and never show up. And you know what? That's the same as a cure. It doesn't make any difference if there's cells somewhere else. There are some of us, I might have cancer in my body right now and I don't even know about it. And if nothing ever happens to my cancer in my body, and then I go on to live a life and I die of a stroke, and then they find out afterwards that I have a cancer, it doesn't make any difference. So the fact that there's something there is not important if it's not doing anything. And remember that philosophy when Harriet talks to you about biological modifiers, where we know that there's cancer elsewhere, but it's not doing anything. And that's the goal we try to achieve if we can't remove it. So going on, this is basically what we're trying to avoid. What we're trying to avoid when we see 1 or 2 or 3 is this seeding of dandelions in a lawn. And if you see that, you have to treat the entire lawn with weed killer. And what that is chemotherapy. Now, you got to understand, chemotherapy is not like a poison. It's just like in the lawn. When you spray it, it doesn't kill your weeds. It has to get into the roots. It's got to be absorbed by the plant. The plant then gets the damage from it, and then it withers away. But the rest of the grass doesn't, because it can correct the damage. And it's the same thing with cancer. When we do chemotherapy, it's basically getting into the normal cells and the cancer cells. The difference is that the normal cells can correct the damage, the cancer cells can't, and that's how the concept works. On the other hand, some of the normal cells won't be able to correct the damage and they will die off. But we have so many normal cells that if some die off, the rest of them will take over the job. On the other hand, we may have some normal cells that may have so many that die off, we get symptoms. The symptoms may be diarrhea, and may be change in your white count or the red cell count, and those are some of the side effects from the chemotherapy. By the same token, sometimes cancer cells get so smart that they can correct the damage and may either persist or come back, and that's what we call resistance to the treatment. So this is the stage we want to treat the patients before it gets to where it's just all over the entire lawn. These are patients who have had more than one, and we know that if we don't treat it, it's just going to become one confluent growth of tumor. Now, back in the 50s and 60s, other people before us actually came up with a concept of using chemotherapy just to the extremity. They said, why give it to the entire body if it's only on the arm and it's only on the leg? Why not do regional treatment? Why not put a tourniquet up in the hip area or up in the shoulder area? Put catheters into the artery and vein so we can put the drug that goes in and out of the arm or in and out of the leg and not have anything go to the rest of the body. This way you can give much higher doses that the body couldn't tolerate, but the extremity can, flush it out, recirculate with normal blood, take the catheters out, and see what response we have. And the problem with that is the drugs that many people were using, and when I say many, there's only about 8 centers in the world that do this. In the country, about 3 or 4. The drug that's being used also has a lot of side effects and toxicity. So we started back in the 80s to use something called DTIC, which had very little side effects to the tissues. And this is a patient where this is in the groin, and we can slip the artery and vein into the main artery and vein of the leg. The catheters go in, then we can do that for the arm as well. Hook it up to a perfusion pump. This is the same pump that we use in heart and lung surgery. And we can show that there's very little systemic leak. By using radioactivity in the pump, we can then put it into circulation, draw blood from the rest of the body, and see what percentage of the drug leaked out of the system into the rest of the body, and it's very little. And these patients have very little side effects. There's no effect on the bone marrow, no effect on the liver. And you can see this patient that gradually the lesion goes away. This is 40 months after the perfusion without any recurrences in the extremity. And I'm going to run through this. This is a different drug we're now using instead, cisplatin. This patient had had resection somewhere else of the recurrence. There's still tumor back there. It's pushing against the artery and vein. The patient was treated with a perfusion, and we made it smaller so we could go back and take it out with a lot less risk. And this is the tumor that we've removed, and the patient was doing well afterwards. I'll run through this. Now, one of the things that patients say is, yeah, that's all well and good, but you can't do this operation. It's a big operation, and you can't do it in people who are older. And we looked at our data, and we looked at patients that we treated in their 70s and 80s and comparing them to younger patients that we treated. And you can see the complication rate in the elderly group was actually less than the younger group. And the complications were really not very significant, mostly wound healing, but no tissue necrosis, no loss of limbs, as it has been with other drugs. So the point I'm trying to make is not that older people do better, but obviously you select out the patients, and as long as you select out patients, age is not a contraindication for these treatments. So in summary, let me just say that patients who have non-visceral metastases actually have a much better durability and percentage of responses. Elevated LDH is one of the areas that we're looking at because it's the most important predictor. And if we can do complete resection, we have much more durable results. Very quickly, another patient who had had resection. This is a patient who had a recurrence, had one perfusion. Several years later, had recurrence again in the leg, had a second perfusion, and you can see in follow-ups there was durable response. This was a patient who had recurrence in the arm. She was legally blind because of glaucoma, and this is her dominant hand. She was advised to have an amputation for the recurrences. The family came to seek other advice. We went ahead and did perfusion. We had control of that with that loss of the limb. And another patient who had multiple recurrences in the leg had the perfusion, and about a year later sent me a photo of her wedding, thanking me for the ability to dance at her wedding. And more importantly, are these new advances that Harriet's going to be talking to you about, and these are the areas that we're very excited about, which is much more important, I think, than surgery. Thank you very much.